The presentation will be about 45 minutes with a Q&A to follow. All attendees will be kept on mute throughout the presentation. My colleague and I will be monitoring the chat, so please feel free to enter any questions or comments via the chat function, and we will have Dr. Naides address them at the end of the presentation. Thank you for joining us today, and allow me to introduce Dr. Stanley Naides. Dr. Naides is a board-certified internist with subspecialty certification in rheumatology. He received his bachelor's degree from Princeton University in biochemistry and attended the Hebrew University in Jerusalem. He received his MD from Drexel University and trained in internal medicine at the University of Miami-Jackson Memorial Hospital and at Temple University. Dr. Naides completed fellowships in rheumatology at the University of California, San Diego, in immunology research, and at Harvard Medical School. He then joined the Division of Rheumatology at the University of Iowa, where he became a tenured associate professor. Dr. Naides subsequently was professor of medicine, microbiology and immunology, and pharmacology at Pennsylvania State University, Milton S. Hershey Medical Center, where he held the Hallowell Endowed Chair, was chief of rheumatology and co-director of the immunology graduate program. In 2006, Dr. Naides entered into commercial industry, leading new assay development and oversight of reference laboratory clinical testing in immunology, neuroimmunology, among other disciplines, and oversaw research, scientific communications, and publications. He recently joined Laboratory Corporation of America, LabCorp, as medical science liaison. He has served on NIH and Foundation Grant Review Study sections. He continues to serve on National Professional Society committees and is currently a member of the Board of Directors of the Autoimmune Encephalitis Alliance. Dr. Naides is the author and editor of more than 100 peer-reviewed papers, book chapters, books, and reviews. Thank you, Dr. Naides.
Thank you, Nashwa. It's a pleasure to be here and to have the opportunity to speak with you all. So let's get started. We're going to be talking today about seronegative rheumatoid arthritis, and in particular focusing on the biomarkers used for diagnosis and what we believe are some novel biomarkers that will aid in filling a diagnostic gap that currently exists. So we're going to describe the frequency of which the classic markers, rheumatoid factor and CCP, are negative in rheumatoid arthritis, and particularly focus on early rheumatoid arthritis where such diagnosis is needed to get the patient diagnosed and appropriately treated. We're going to describe the nature of and the role in rheumatoid arthritis diagnosis of 4 markers: 14338, a protein, SA antibody, CEP1 antibody, and CARP antibody. As many of you know, rheumatoid factor is a classic marker for rheumatoid arthritis, and this particular marker consists of antibodies that target the FC portion of IgG. Now, those rheumatoid factors can be IgM, IgG, IgA, rarely IgE, and they're typically polyclonal, but they can also be monoclonal. And reference interval is defined as the 95th percentile of a normal population. So in a normal population, 5% of your individuals will have rheumatoid factor. And the fact that they have rheumatoid factor is not surprising, since rheumatoid factor is very much part of the initial immune response to bacteria, which enhances complement and cell adhesion. So it's an important part of the initial immune response, and we all have some rheumatoid factor. Now, rheumatoid factor is measured by nephelometry or turbidometry. The difference between the two is exactly whether we're looking at a reflected light off of particles or how much light passes through in the case of turbidometry. Mostly these measures IgM because of the prevalence and multivalency, allowing particle formation to be accelerated. We use ELISAs for identification of class-specific rheumatoid factor, and testing is available for IgM, IgG, and IgA rheumatoid factor. The other classic biomarker is anti-citrullinated cyclid peptide antibody. So this is much more specific for rheumatoid arthritis, about 98% specificity. Rheumatoid factor, as you well know, is often seen in response to chronic infection or to inflammation of a number of different causes. So rheumatoid factor is not particularly specific. The anti-CCP antibody, often called ACPA, another version of anti-citrullinated uh, protein antibody, is more specific for rheumatoid arthritis, and it recognizes citrulline in the context of peptides. Now, we normally do not put citrulline, which is an amino acid, into our proteins. So this is a post-translational modification of arginine in protein in which the terminal amino group on the arginine is converted by an enzyme called peptidyl arginine deaminase to a citrulline by replacing an amino group with an oxygen double bonded to the terminal epsilon carbon. So the initial test was developed using a synthetic short citrullinated peptide, which was conformationally stabilized by putting it into a cyclic form, hence the term cyclic. So there are several versions of ELISA that have been developed over time. Much of the literature will use the newer versions 2, 3, and 3.1. So version 3 represented an improved antigen, which we don't know all that much about because it's proprietary, and it used an IgG detection antibody, an IgG specific conjugate. The version 3.1 uses a bispecific conjugate, IgG and IgA, which increases the sensitivity a bit by adding the IgA detection. And so that's about 70%. But if you look at the sensitivity, particularly in early RA, the sensitivity for rheumatoid factor is relatively low at 57%. And this is an example of one study. CCP antibody sensitivity is 59%. And if you put them together, you get up to about 72%. The specificity, again, for rheumatoid factor is high, but not that high. And for CCP, it's much higher. This specificity was extremely useful when we were confronted with patients with hepatitis C virus infection who had joint symptoms, much polyarthritis, much in terms of distribution, like rheumatoid arthritis, and many of whom, about 40% of chronic hep C patients have rheumatoid factor. So it was very confounding. But we see high specificity for CCP, which was an aid in differentiating rheumatoid arthritis from those with chronic hepatitis C, and which CCP occurs only in about 1 to 2% of patients with hep C. So together, you don't get much more specificity. So if you look at this roundup, you see that there is seronegative rheumatoid arthritis. In other words, absent the classic rheumatoid factor or CCP. In early RA, about 28% of the time, and in established RA, about 12% of the time. So particularly for early RA, there's a significant gap if we just use rheumatoid factor and CCP antibody. So that's where these additional markers come in terms of filling the diagnostic gap, and we're going to speak about each of them in turn. 1433 is a family of chaperonin proteins, and it got its funny name because it was a protein that was originally isolated on a DEA cellulose column elution. It was the 14th fraction, and on a 2D starch gel, it was in the 3,3 position, hence its name. There are 7 known isoforms of 1433, which occur in dimers as either homodimers like gamma, epsilon, and sigma, or heterodimers as alpha, beta, delta, zeta, or theta, tau. We're going to obviously focus on eta for very important reasons. But as a class, what these proteins do is the dimers form a cup. And the cup functions in one of 3 ways. It either clamps a binding partner and promotes conformational change in its target, altering its biological function. It will either mask interaction between a binding partner and its interactions with other proteins, or it'll form a scaffold that will enable two proteins to come together in close proximity and allow them to interact and carry out their respective functions. 14,3,3 in particular is found on chromosome 22 in the long arm. It encodes a 246 amino acid polypeptide chain, which weighs about 28 kilodaltons. And these proteins are highly homologous to murine and bovine forms. So they are very important players in any of a number of cellular functions across species, hence their conservation. So this is an example of the different functions. Here, a target protein which becomes phosphorylated is able to tuck into the 14,3,3 eta through a number of acidic amino acid sequences tucked within the structure of 14,3,3 eta. It can actually provide regulation of subcellular localization because it will help move proteins around the cell, and it can inhibit interactions of a target protein which becomes phosphorylated with its target protein or DNA. And this 14,3,3 has been involved in regulating a number of protein DNA interactions. And it can provide a scaffold in which proteins becoming phosphorylated are able to tuck in to the two clefts and therefore interact appropriately. So that's 14,3,3 and how it functions. So let's talk about 14,3,3 eta and where it comes from. 14,3,3 is released from synovium and brain. So as long as you have an intact blood-brain barrier, what you see in the serum is coming from synovium. And it turns out that synovium does not have a basement membrane. So what is in the synovial fluid within the joint is free to equilibrate with the patient's serum. And during inflammation in the joint, 14,3,3 eta is released into the synovial fluid. And so if you look here at this blot of various 14,3,3 isotypes, if you look at synovial fluid in someone who has inflammatory arthritis, you see really only the eta form is expressed. And if you look at the patient's serum, you can see that there is detectable 14,3,3 eta. And the ratio is about 5:1 in terms of concentration across the synovial to serum gradient. These are just positive controls for keratinocytes from the skin, which do not release their 14,3,3s. If you take 14,3,3 eta and put it on fibroblasts in culture, in a dose-dependent way, it increases production of matrix metalloproteinase 1, also known as collagenase. And so 14,3,3 eta itself is pro-inflammatory. As a result, when you have 14,3,3 eta released, it feeds back on the cell. It induces a number of signaling pathways that lead to production of inflammatory cytokines and also matrix metalloproteinases, such and rank ligand, which chew up joint structures. The assay is performed as a sandwich ELISA using two monoclonal antibodies that are specific for the eta isoform, one to capture 14,3,3 eta and the other as a detection antibody. The analyte is stable at room temperature and 4 degrees for at least 7 days and after 3 freeze-thaw cycles. What's important is that the assay is not impacted by interfering substances, common interfering substances, and in particular rheumatoid factor, which is, as we pointed out, interacts with the FC portion of immunoglobulin. And within adults, there is no reference range differences for by age, gender, or ethnicity. Now, if you look at where we find 14,3,3 eta as shown here, looking at a threshold of a reference range of less than 0.2 nanograms per mil, we see that for rheumatoid arthritis overall, there is a sensitivity of 77% with a specificity of 83%. And you can see if you look at rheumatoid arthritis, that's established rheumatoid arthritis, you can see that there is a range of 14,338 across the measurable range up to 20 nanograms per mil, and obviously some are much more than that. In patients with rheumatoid arthritis. If you look at early rheumatoid arthritis, you find that likewise there's elevated. But if you look at controls, whether they're healthy, they have other arthropathies or connective tissue disease or infectious diseases or osteoarthritis, you don't see those elevations. You see a few people who may have some low positives. We'll come back to that. So if you look at, in this particular study by Maksimovic, if you look at early RA and you look at CCP, 59% sensitivity, rheumatoid factor 57%, 14338 is 64%. So as a standalone, 14338 did a little bit better than your classic CCP and rheumatoid factor. If you look at CCP and rheumatoid factor together, you have 72% sensitivity, hence the gap of 28%. But if you add all three markers, you get up to 78% sensitivity, which is an 8% improvement. So 14338 will complement the classic markers of CCP and rheumatoid factor in identifying patients with early RA. So if you look at seronegative early RA as just a separate group, you find that about 21% of those with early RA are 14338 positive. And amongst those who have established RA more than 6 months of disease, it's 67% in the rheumatoid factor negative, CCP negatives. So what happens when you find 14338 in healthy donors? Here's a study that looked at 134 normal healthy individuals using the same 95th percentile cutoff for a reference range of less than 0.2 nanograms per mil, and the reportable range from less than 0.2 to greater than 20. 6 of those 134, about 4%, had elevated 14338 levels. One had elevated 14338, the one with the highest level, also had rheumatoid factor and IgG rheumatoid factor. And we know from studies of individuals with preclinical rheumatoid arthritis, what you might say autoimmunity with either rheumatoid factor and of 2 isotypes or rheumatoid factor and CCP, those individuals have increased risk of going on to developing rheumatoid arthritis. And then there was another patient who had 14338 and a low titer IgM rheumatoid factor. None of these patients had CCP antibodies. So it raises a question: is if you see these markers in healthy individuals, are these people at risk for developing rheumatoid arthritis? If you look at 14338 in individuals who present with inflammatory, undifferentiated arthritis, those who have, this is from Van Schottenberg, those who have 14338 have a lower risk of going on to developing rheumatoid arthritis, whereas those that are positive will go on more likely to develop RA. And so there's, if you have rheumatoid arthritis, if you have a 14338 in the setting of an undifferentiated arthritis, the likelihood ratio of going on to getting a diagnosis of rheumatoid arthritis increases about 8-fold. If you do have a diagnosis of rheumatoid arthritis and you are 14338, you're going to have worse disease in terms of disease activity score, health assessment questionnaire, excuse me, SED rate, CRP, rheumatoid factor, and CCP. So 14338 positive patients have significantly higher clinical and serological measures. If you look at erosive disease at the time of 14338 positivity, those individuals with early RA or established RA have increased 14338 levels. So there's an association between having a high 14338 level and having more likely having erosive disease. And if you have 14338 and at baseline, and then look at how the patient does in terms of joint erosions using a modified SHARP score, those individuals who have 14338 positive at baseline go on to develop erosions earlier and have worse erosions scores at 5 years, as opposed to those who are negative, who have a delay in their onset of erosive disease. So 14338 at baseline predicts an aggressive joint damage trajectory. If you add CRP, C-reactive protein, into the mix with 14338, those two together are associated with increased risk of joint damage progression. And as you can see here, those individuals who have both will more likely progress to having increasing worse SHARP scores. So 60% of the patients who are positive for both CRP and 14338 at baseline have radiographic changes of greater than 5, defined by the SHARP score, over 30 months. And so the question is really, should these groups of individuals, should this group of individuals be treated more aggressively? So we've used osteoarthritis as a control. And here is a study that we did with the Arthritis Internet Registry, AIR, now called Forward, surveyed by questionnaire of physician and medical records. And we looked at 166 physician-diagnosed osteoarthritis subjects. 11 of these had 14338. What's interesting is that one of those who were positive had rheumatoid factor CCP off scale and 14338 and was reclassified as rheumatoid arthritis after seeing these results. One patient had normal CRP, rheumatoid factor, and CCP, but had 14338. That was positive. And subsequent to that sampling, was diagnosed with psoriatic arthritis based on swelling in 2 fingers, joint pain, and changes in the fingernails, all absent of a prior psoriasis or family history of psoriasis. And we'll come back to psoriasis in a moment. And one physician was diagnosed osteoarthritis patient, had previously been treated for rheumatoid arthritis with methotrexate and etanercept, and our CRP was elevated, rheumatoid factor CCP and 14338 were off scale, clearly someone with rheumatoid arthritis. So excluding these 3 subjects, the specificity in an OA subject group for 14338 was 95%. So 14338, we believe, may be used to help identify rheumatoid arthritis or psoriatic arthritis patients amongst those being followed for osteoarthritis, which may be particularly useful in the primary care setting. So why psoriatic arthritis? It turns out that patients with psoriasis do not have elevated 14338. Those with arthritis, which is non-erosive, really do not have 14338, but those with erosive disease may have a 14338 that's elevated, typically not as high as in some rheumatoid arthritis patients, but this suggests that rheumatoid arthritis and psoriatic arthritis may share some pathogenic pathways. Now, fortunately, it's typically relatively straightforward to differentiate rheumatoid arthritis and psoriatic arthritis on the basis of clinical findings. So one can differentiate the two. But in a setting of psoriasis or patients with psoriasis with some arthritis that's not erosive, finding an elevated 14338 may be a clue that the patient is developing erosive disease. So let's go on to the second marker, which is SA, anti-SA antibodies. Now, this particular marker was discovered in rheumatoid arthritis serum by its reactivity to placenta. And the target is citrullinated vimentin. Now, vimentin is found in synovial mesenchymal cells and macrophages as an intermediate filament, which is part of the cell cytoskeleton. And here you see a macrophage undergoing apoptosis, and it's stained with an antibody for vimentin, so you can see the network. So during apoptosis, there's activation of PAD4 enzyme within the cell, which then citrullinates a protein. And so vimentin is citrullinated and subsequently secreted during macrophage apoptosis. That's how it comes to be. This then is, the citrullinated vimentin is a new antigen. It's not self, it's not seen as self, and so the immune system makes an antibody response to it, which is detectable in an ELISA format. The sensitivity for anti-SA antibodies in early rheumatoid arthritis is 20 to 25%, and in established rheumatoid arthritis is about 46% with a very high specificity. What's also important is that anti-SA antibody predicts more severe disease when elevated in early RA. And you can see that here in early RA, individuals who are SA positive versus SA negative, they have more frequent rheumatoid factor, they have more swollen joints, C-reactive protein is higher, more of them have erosive disease, they need more DMARDs, they need more prednisone, and practically none of the SA positives have inactive disease at time of an early RA. Now, there is some overlap with CCP antibodies, but SA targets a unique group of autoantibodies in terms of their detection. 14.3% of anti-SA positive patients lack CCP antibodies. So again, a CCP negative individual may have an anti-SA antibody. If you look at individuals who have both SA and CCP antibodies, there's no correlation between the titers. So they appear to be independent responses. And CCP antibody negative rheumatoid arthritis patients are SA positive about 3.1% of the time. So SA patients have increased prevalence of joint erosions. And when you compare SA positive to CCP negative patients, SA patients have more joint erosions. And when you compare CCP positive, SA positive patients to CCP positive and SA negative patients, those who are SA positive still have more erosive disease. So our third marker is anti-citrullinated alpha enolase antibody. Now, alpha enolase 1 is a glycolytic enzyme that catalyzes the conversion of 2-phosphoglycerate to phosphoenolpyruvate. This is a step that's important in glycolysis and other metabolic pathways. The other thing of interest is that membrane alpha enolase, when it's found on the membrane, is a receptor for activating plasminogen. With activation of plasminogen, there is stimulation of cell migration. So alpha enolase will bind to DNA and messenger RNA and helps regulate gene transcription and translation. And as we see that in cancer cells where it's overly expressed and changes gene transcription and translation. During inflammatory stimulation, alpha enolase translocates from the cytosol of the cell to the cell membrane. And so when it's expressed on the surface of monocytes and macrophages, it induces a robust synovial inflammation in rheumatoid arthritis. And so now we have activated macrophages, monocytes that go on to become activated macrophages, and we get induction of synovial inflammation. So in rheumatoid arthritis, we see alpha enolase 1 is also citrullinated. The method we use to detect it is by ELISA. Its sensitivity is 23.9 to 72%, depending on the study. Specificity is high. Just like SA, there's an overlap with CCP antibodies, but there's also a unique set of autoantibodies that will only recognize citrullinated alpha enolase 1. It's present in anywhere from 4 to 21% of CCP antibody negative RA patients, again, depending on the study and the cohort. See, CEP1 antibody can predict the onset of RA in preclinical rheumatoid arthritis because it has a low prevalence in individuals who are symptom-free, but have not yet developed their rheumatoid arthritis, and they're about 12 or more years out before they develop their symptoms. And that prevalence of anti-CEP1 antibody rises to about 40% when they're less than 3 years out prior to developmental onset. But at diagnosis, when they now have symptoms, it's over 67%. So seeing a rise in CEP1 antibodies in an asymptomatic individual suggests progression to clinical disease. CEP1 positive rheumatoid arthritis patients have significantly higher disease activity scores than those who are negative, and they have more erosions. So again, a marker of perhaps more aggressive disease. If you look at the associations of joint erosions with CEP1 antibody, those who have high CEP1 titers or concentrations will be at increased risk, have odds ratios of 5 or more of developing erosive disease. And this same kind of association with worse disease is seen in the setting of rheumatoid arthritis associated interstitial lung disease, so that individuals who have high CEP1 concentrations may indeed be at increased risk for having interstitial lung disease. So here is the fourth marker, which is anti-carbamylated protein or anti-CarP antibodies. Now this comes about because urea is in equilibrium, not a favored equilibrium, but nonetheless there is some concentration of cyanates that are a result of breakdown of urea, which can then become isocyanic acid as it loses, as it takes on, if you will, hydrogen from water. Thiocyanates can also be turned into cyanates by the action of the myeloperoxidase enzyme that we see in neutrophils. And so the isocyanate is reactive with the terminal, either the alpha N-terminus of proteins or the epsilon amino group in side chain of lysine. And so as a result, these are changed to this structure, and you see now a carbamylated protein, which is now also a new antigen, a neoantigen, which the immune system sees and makes antibody to CarP. So if you look at a mouse study of what carbamylated peptides do, if you introduce them to the mouse, it induces activation and proliferation of CD4 T cells, production of IL-10, gamma interferon, and IL-17. The mice developed an erosive arthritis, and they develop high titer CarP antibodies. So the CarP peptides are definitely pro-inflammatory. The method by which we measure anti-CarP antibodies is ELISA. The CarP antibodies in rheumatoid arthritis have a sensitivity on the order of 35 to 48%. Specificity is high, about 93 to 97%. In CCP positive rheumatoid arthritis patients, we'll find CarP antibodies 49 to 73% of the time, but in CCP negative individuals, we'll find CarP antibodies 35 to 52% of the time. Many of these are 16% of these patients will have IgG antibodies to CarP and about 30% IgA antibodies to CarP. So in rheumatoid factor negative rheumatoid arthritis patient, CARP antibody is positive about 55% of the time. And in seronegative RA patients lacking both rheumatoid factor and CCP, anti-CarP antibody is positive about 24% of the time. So it's positive in about a third of early arthritis patients and in about a fourth of seronegative patients. So CARP predicts onset of rheumatoid arthritis in individuals with preclinical RA, again, individuals who have no symptoms, but who have either rheumatoid factor and CCP or two isotypes of rheumatoid factor. So in a cohort of 340 arthralgia patients with positive IgM rheumatoid factor or positive CCP, but not meeting criteria for a diagnosis of rheumatoid arthritis, 39% were CARP antibody positive. And it was significantly associated with progression to rheumatoid arthritis. So 51% of these patients progressed, who were CARP positive, progressed to rheumatoid arthritis versus 25% who were CARP negative. So when patients do develop disease, the presence of CARP antibodies is associated with more active disease and a higher risk of developing joint erosions, particularly when there is also present rheumatoid factor or CCP. CARP antibodies are associated also with interstitial lung disease in rheumatoid arthritis patients. So again, you need to think about evaluating patients for early interstitial lung disease. So in closing the diagnostic gap, we have added 1433A SA antibody, CEP1 antibody, and CARP antibody. So they add diagnostic sensitivity to rheumatoid factor and CCP antibody alone. They alert the clinician to consider a more severe disease, and they add prognostic value. They alert the clinician to the likelihood of a more aggressive joint erosive disease, which may require more aggressive therapy, and they alert the clinician to consider screening for interstitial lung disease. So thank you, and I'm happy to answer questions online now, or if you think of them later, feel free to reach out to me at this contact information.
Thank you, Dr. Naides. We do have a question from Dr. Lee. What about anti-mutated citrullinated vimentin anti-MCV antibodies? Any utility of this one?
Yeah, I mean, it's a comparable assay to our anti-SA antibody assay. In my experience, if you look at rheumatoid factor and CCP negative individuals, it adds about 5% sensitivity to detection of it, of rheumatoid arthritis. So it contributes somewhat. I particularly prefer the SA antibody. I think it's been around longer. Also, when the assay is made, it's the vimentin is mutated, hence the term, in order to include more arginines that can be citrullinated. And so the base vimentin is not the native vimentin that is being detected. It's a mutated vimentin which has extra citrullination. So it's not quite the same as SA.
Okay, any other questions? Feel free to put them in the chat. All right, it looks like that was it. So thank you all for joining us today. And again, you'll be receiving a link to the recorded session. We hope you found today's discussion of value, and please keep an eye out for the next in our series, Cases in Biologic and Other Specialized Therapeutic Drug Monitoring, scheduled for October 19th. Once you receive the link, if you have any other questions, please feel free to reach out and we'll be happy to get back to you. Thank you very much and have a great afternoon.
Thank you all.